Khanuja, doing a fellowship here at Jefferson, is going to become a national expert on fetal pleural effusions, and hopefully she'll be getting the phone calls of how to manage these babies after we finish our review together sometimes this year. So Kavisha is going to teach us today a lot about embryology. I learned so much from her presentation already, and she's gonna talk about basically very important really is etiology, differential, and management as well. And thank you, Dr. Khanuja, for taking on this very difficult topic. And you're not gonna know how difficult it is until she gets started.
Thanks, Dr. Al-Kwatli. Good morning, everyone. Today I will be presenting on the fetal pleural effusion. So before I start discussing more information about fetal pleural effusion, I'd like to start this presentation with discussing a case from last year. This is patient KN, who was a transfer of care from an outside hospital, who had a growth scan in the setting of obesity on 12/15 at 33 weeks, and that growth scan demonstrated polyhydramnios, bilateral pleural effusions, abdominal ascites, and skin edema. This patient did have prior ultrasounds. In early anatomy at 18 weeks showed an overall normal anatomy with suboptimal views of the face and heart. In anatomy at 22 weeks and 5 days demonstrated normal anatomical views. Given the findings on the ultrasound, the patient received betamethasone and underwent thoracocentesis. First on 12/15, during which 110 cc's of clear fluid was removed, and then underwent a second thoracocentesis on 12/19, during which 85 cc's of straw-colored fluid was removed. The patient was then subsequently transferred to Jefferson, given ICN level of care and availability for ECMO. On arrival to the outpatient offices at 8:33, the ultrasound performed on 12/22 at 34 weeks and 0 days showed the following. On the right, in the transverse plane, we have significant bilateral pleural effusions and skin edema. On the left, we have a coronal view of the fetal chest, again demonstrating the pleural effusion. An amniocentesis and thoracocentesis was performed by Drs. Baxter and Dr. Iyer. This image here demonstrates the needle being placed into the abdomen. In amniocentesis, removed 50 cc's of clear amniotic fluid, which was then sent for karyotype and chromosomal microarray. The thoracocentesis was then performed with 135 cc's of straw-colored fluid removed from the right lung. The picture on the right is a transverse view of the thorax after removal of fluid from the right lung. From the right pleural space. Attention was then turned to the left lung, where 45 cc's, again, of straw-colored fluid was removed. The image on the left demonstrates a transverse view of the thorax after fluid was removed and overall post-procedure. In terms of the antenatal management, the patient following the procedure was recommended for induction of labor given fetal hydrops with worsening fetal status based on rapid accumulation of pleural effusions. The patient had 4 prior vaginal deliveries. During the induction process, the patient was noted to have unstable lie and brisk bleeding concerning for placental abruption, and ultimately underwent a stat cesarean delivery at 34 weeks and 1 day. In regards to the neonate, at delivery, the neonate was 2,400 grams with APGARs of 2 and 6. The infant was immediately placed on high-frequency oscillatory ventilation on admission with a chest tube placed on the right side with 95 cc's of straw-colored pilus fluid, per the note, removed, with improvement of expansion of the lung.
You have to come back for the straw-colored and pilus at the end.
The fluid analysis showed 97% lymphocytes, no triglycerides or cholesterol, and torch panel was negative. The amniocentesis showed normal chromosomal microarray and normal CMV. Here is a radiograph demonstrating the pleural effusion. The picture on the right demonstrates the bilateral pleural effusions, with the right greater than the left. The picture on the left demonstrates the neonatal chest after placement of the right chest tube with decrease in right pleural effusion. However, we still continue to see a left pleural effusion in this stage. In regards to this neonate's course, he was ultimately transferred to Nemours on day of life number 3 for management with the lymphatic team. The etiology at the time of discharge was believed to be due to chylothorax, but unfortunately, there's no further records that are noted in the neonate chart, but it didn't say deceased infant, so I'm assuming still alive. But I'm not really aware of what occurred with the neonate after discharge. And although this case occurred last year, I thought it would be a valuable starting point for today's presentation regarding pleural effusion as it demonstrates diagnosis of antenatal. To further understand fetal pleural effusions, I will start off by reviewing the embryology of lung development. From there, I will be discussing the definition, etiology of pleural effusions, and diagnosis. And finally, I will discuss what the antenatal course and management will look like in fetuses with pleural effusions. In order to understand how the lung can be infected by intrauterine conditions, it is important to appreciate how the lung develops. So as a review, we'll start off with the process of gastrulation, which occurs during week 3 of human development. The blastocyst is comprised of 2 different cell types: an outer cell mass, the trophoblast, which facilitates implantation and formation of the placenta, and the inner cell mass, the embryoblast, which is responsible for the formation of the embryo. During week 2 of embryogenesis, the embryoblast divides into the epiblast and the hypoblast, forming a 2-layer structure called a bilaminar disc. During week 3, this bilaminar disc undergoes gastrulation, which is the process in which the 2 cell layers become 3 germ layers: ectoderm, mesoderm, and endoderm. The differentiation and invagination of the epiblast is controlled and orchestrated by the primitive streak, which is the groove in the midline of the epiblast. This results again in those 3 germ layers that I discussed. The endoderm and mesoderm will be highlighted in the lecture today because the epithelial lining of the respiratory tracts, the trachea, bronchi, and alveoli, are derived from the endoderm, and the airways and smooth muscles of the lungs are derived from the splanchnic mesoderm, as demonstrated in the image above. The lungs begin as an endodermal outgrowth from the ventral surface of the embryonic foregut at around day 22. This outgrowth, the primary lung bud, is highlighted right here. The outgrowth elongates caudally to form the trachea and becomes separated from the foregut endoderm by the formation of the mid-ventral groove that deepens and then constricts. The lung bud then branches to form the 2 major bronchi and then rapidly divides to form branch structures of the endoderm. The continued branching is demonstrated in this image and eventually gives rise to the lining of the entire bronchial tree, from the larynx to the alveoli, including multiple cell types within the airway epithelium. As the epithelial tubes branch, they become invested with the splanchnic mesoderm, which forms again all the non-endodermal structures. And then we have increasing complexity of the bronchial tree that occurs through a process of branching morphogenesis, which is similar to seen in the developing kidney and other gland-like organs. In the lung, this branching of the trachea bronchial tree occurs as a result of interactions between the epithelial, which again is that endodermal cells, and the cells of mesenchymal origin. The other thing that's important to know is that around this time, the pulmonary vessels have formed themselves. The pulmonary circulation, which is not shown in this slide, is formed from the 6th pharyngeal arch artery, which we learned in med school during embryology. Following the embryonic phase of the lung development, the primitive airways enlarge and grow by repeated branching at the distal ends towards the periphery of the lung. The future airways have a liquid-filled lumen and are lined with columnar epithelium. The mucus glands formed from the epithelial layer begin to secrete secretory activity, giving the lung the appearance of a secretory gland. And this is fluid that I will be discussing later on in the presentation. This phase continues to see the glandular phase until around 16 weeks post-conception. The pulmonary gas exchange at this point is not possible because of the poorly developed vascular bed in the surrounding mesenchyme. The primitive epithelial cells then began to differentiate into multiple cell types: basal, goblet, ciliated, and non-ciliated cell. Let's take a closer look at the different cells that are here. Number one is the lung mesenchymal cells that were just described. Number two, which is highlighted here, are the type 2 pneumocytes of alveolar cells, and 3 are the capillaries. The next phase is the canicular stage, and this is between 16 to 26 weeks and is characterized by widening and lengthening of the bronchial tree, resulting in a substantial increase in the potential airspace and a decrease in the amount of mesenchymal tissue. The terminal airways, which ends in rudimentary saccules, increase in complexity, and the amount of mesenchymal tissue surrounding the terminal units decrease. This mesenchyme becomes increasingly vascularized and attenuated, reducing the distance between the blood capillaries and adjacent terminal air spaces. The alveolar progenitor cells then begin to differentiate into type 1 and type 2 alveolar cells, as demonstrated here. So again, this is showing the type 1 pneumocyte, which is highlighted in the number 1, and then we have type 2 pneumocytes that are here. 3 is also once again demonstrating the capillaries. And type 1 alveolar epithelial cells, they have like long, thin cytoplasmic extensions, which increase the surface area for gas exchange. And type 2 produce and secrete surfactants.
The canicular stage, since it covers 16 to 26 weeks, some of that period betamethasone will be helpful, and some of that period betamethasone won't be helpful. Do they divide the canicular stage at all?
Not that I was able to see, and I think a lot of the reason for that is these are all based on shape models, so it is a bit difficult.
Yeah, I guess it just makes me wonder whether this should really be 2 separate stages, since we know that.
And towards the end, we start to see this.
Which makes me think that there is some sort of difference in.
There probably is, and that's definitely something that I'll try to look into, but from what I was able to see from the different embryology websites that I went through, there wasn't really any division that I was able to specifically find. I think it's more like ideally after the 26 weeks, which I'll get into in a moment, we really start to see more of that gas exchange occur. This is just sort of setting up for that gas exchange.
I think it's a continuum. It's not like all these, it's not like, oh, now week 17, this is here. It's like a continuum. So I don't know if they're able to really differentiate like week by week.
Effusionss says it's a spectrum.
Yeah.
Getting into our next phase is the saccular phase. And so saccular stage rather, which occurs from 26 to 36 weeks. And the terminal saccules, the precursors of alveoli, are formed by the process of septation in the terminal air spaces. They are present in the lung from around 26 weeks until the completion of alveolarization. Gas exchange can occur across these saccules as the blood-gas barrier now has thinned out due to the thinning of the interstitial tissue and the fusion of the basement membrane type 1 alveolar cells and the capillary endothelial cells. And so once again, we can take a little closer look into the histology. Again, 1 is demonstrating type 1 pneumocytes, 2 is demonstrating the type 2 pneumocytes, and 3 are the capillaries. Now, the final phase that we think of is the alveolar stage, which occurs from 36 weeks to 2 years. And so definitive alveoli first become apparent around 32 weeks of gestation. And the process of bulk alveolarization continues until 2 to 3 years after birth. Alveoli are formed again from saccules by the process of secondary septation. So essentially, it's just a continued septation process. And all of this septation process in particular is dependent on the elastin deposition at the tips of the secondary crest by the myofibroblasts. If it's disrupted, this process, then alveolarization is inhibited. And secondary septation is what leads to the large increase in the surface area for gas exchange within the lung. So again, we're starting every single step of this process is making it possible for improved gas exchange. But again, the alveolar stage is where we really, really see that improvement. And it corresponds to, again, preterm and term. So things when we're thinking about even counseling patients on steroids, et cetera, delivery, these are, in terms of lung development, important things to keep in mind. Together with the secondary septation, the density of blood capillaries surrounding the gas exchange just increases markedly. And then finally, the final stage of lung development is considered to be a formation of the single capillary network from a double capillary network. So here I have two photos or images, one that demonstrates this stage prior to birth, in which the alveolar phase, so that's right here, of the alveoli are formed from the terminal endings of these saculi, with their timing increasing in diameter. After birth in the alveolar phase, more and more and more alveoli form from the terminal endings of the alveolar saculi. And with time, again, we're having that increase in diameter. So this figure right here summarizes the stages of lung development. The lungs, again, are breathing organs that are unnecessary for intrauterine existence, but however, they must be developed to such an extent that they are immediately ready to function. This explains why this entire development process is from the embryonic period all the way until post-birth. And nonetheless, the lungs are an important source of amniotic fluid, so something for us to keep. I also want to spend a few minutes discussing fetal lung physiology to understand the impacts of pathology such as pleural effusions on the fetal lung itself. We know that the fetal lung is not developed in a closed state. Instead, the future air spaces of the lungs are partially expanded with the fetal lung fluid that we had described earlier throughout much of gestation. Now, fetal lung liquid, as it's called, is a secretory product of the lung epithelial that is different from other fetal fluids. It's not plasma, it's not lymph, it's not amniotic fluid. Fetal lung liquid is characterized by having high chloride concentrations compared to plasma, lymph, and amniotic fluid, and low concentrations of bicarb and protein. The secreted lung fluid, it follows the bronchial tree to the pharynx via the trachea and larynx. From the pharynx, it may either be swallowed or it may pass into the amniotic sac. So we know that fetal lung liquid is known to make a contribution to the amniotic fluid, as substances of pulmonary origin, such as surfactant, can actually be detected in amniotic fluid. Amniotic fluid does also come into the trachea via the pharynx during episodes of fetal breathing movements when the glottis dilates. And although the flow of fetal lung liquid across the trachea can be bidirectional, the net flow is always, always, always away from. Now, the volume of fetal liquid within the future air spaces, and therefore the degree of lung expansion, is now known to be vital for normal lung development. From fetal sheep models, if the lung liquid, again, all of this is coming from fetal sheep models, this data, but if the lung liquid is continuously removed in fetal sheep, the resulting decrease in lung expansion causes a cessation of lung growth and inhibition of structural development. Obstruction of the fetal trachea, which causes lung liquid to accumulate within the future air spaces and increases lung expansion, leads to augmented lung growth and enhanced structural development. And although an increase in fetal lung expansion is critical for promoting fetal lung development, little is known about the underlying mechanisms. It's likely, shout out for the genetics, because of the transcription. Volume of lung liquid within the lumen, and hence the degree of lung expansion, is also influenced by a transpulmonary pressure gradient and the resistance of the upper airway, not the rate of production. So episodes of fetal breathing movements, which is demonstrated in this image, can alter the volume of luminal lung liquid by altering the transpulmonary pressure and the resistance of the upper airway, especially in the larynx. Now that we understand a little bit more about fetal lung liquid and lung expansion, I want to briefly discuss the different factors affecting lung liquid volume and expansion, of which, again, most of this information is actually derived from fetal sheep in utero. Fetal breathing movement is one of these factors. And the first thing to understand is that the lung has a high level of compliance, which means a small change results in a larger change in the level of lung expansion. What we know is that the fetal breathing movements can affect lung expansion by altering transpulmonary pressure and resistance to the upper airway to both the influx and efflux of liquid to and from the throat. What we also know is that prolonged reduction in fetal breathing movements can lead to a reduction in fetal lung expansion, which is what we see in mechanisms such as fetal hypoxia. Fetal posture also can affect the transpulmonary pressure, leading to changes in expansion. For instance, fetal trunk expansion, which is when the diaphragm moves into the thorax, can lead to the loss of lung liquid and a reduction in lung expansion, which can be seen in all diagrams. And then thoracic volume. So a reduction in thoracic volume can expect to restrict the degree to which the fetal lung can expand. This can occur in cases when there's intrathoracic masses or intrapleural fluid, like pleural effusions. And also upper airway resistance is another factor. Other factors that contribute to lung pathology is the amount of time the lung is sustained in under expansion in the lung. What we know is that chronically underexpanded lungs are hypoplastic and have reduced tissue mass. Reduced luminal volume, thicker walls between air spaces, fewer terminal air spaces, saccus or alveoli. We also know that because of under expansion, there's a reduction in branching terminal airways that leads to the reduction in alveoli and surface exchange available for gas exchange. And then finally, pulmonary vasculature is also affected by fetal lung hypoplasia, resulting from prolonged underexpansion, leading to the attenuation in vascular development. So it's thought that steroids ameliorate this underexpansion of the vascular. Now that we have hopefully a little bit better of a sense of embryonic development of the lung, let's dive into fetal pleural effusions. So what is a fetal pleural effusion? A fetal pleural effusion is a condition with identified fluid collections in the pleural spaces of the fetal thorax that was actually first described in 1977. The pleural space is defined as a potential space that is bound by visceral and parietal pleural mesothelial membranes that line the chest wall and lung surface. This image here demonstrates what that space exactly is. Fetal pleural effusion can either be identified or it can be identified as part of hydrops, which is what we saw in the patient case that I had described earlier. For today's purposes, I will only be discussing etiology specifically related to isolated pleural effusion. Again, these etiologies may or may not go on to develop hydrops, but have been associated specifically with isolated pleural effusions. The incidence of fetal pleural effusion is estimated to be 1 in 15,000, although overall rate may be higher due to undiagnosed cases. We know that male fetuses are more affected compared to female fetuses in a ratio of 2 to 1. And bilateral pleural effusions are more common and found in 58 to 74% of cases. Fetal pleural effusions have the potential pathophysiologic consequences because they may potentially be responsible for fetal and neonatal death. These consequences include pulmonary hypoplasia, again due to chronic intrathoracic compression, hydrops, which can develop from the mediastinal shift, cardiac compression, and venal cable obstruction, which diminishes venal return to the heart, resulting in a low cardiac output state. Prematurity as a consequence of excess amniotic fluid due to esophagus compression, and compression of the esophagus may also lead to polyhydramnios. This image right here just shows it is unfortunately an autopsy of a fetus that had pleural effusion, and you can see that pulmonary hypoplasia. Now, there is a wide range of potential etiologies. Fetal pleural effusions can either be primary or secondary. Secondary meaning that it's part of a more complex disease. Primary pleural effusion is a diagnosis of exclusion and cannot be conclusively confirmed prenatally. Typically, primary pleural effusion is generally chylous in origin, and it occurs as a consequence of accumulation of lymphatic fluid due to atresia, agenesis, or fistulas of the lymphatic duct. It is also the most common cause of pleural effusion in the neonate. Now, there's certain aspirated fluid characteristics. So in the fetus, what you'll tend to see is clear and straw-colored fluid because lymph fluid doesn't contain chylomicrons as the fetus is in a fasting state. So when you think back to the case that we had discussed earlier, during the 3 thoracocenteses, it was straw-colored fluid because of the fasting state of the fetus. Now, in the neonate, the chylous effusion is generally milky due to the presence of chylomicrons.
And this is fascinating information that Kavisha is sharing with you, really. You know, without this fetal therapy, we wouldn't have learned this right now. So remember this white syringe here, this is not straw color, this is like milk, basically. This is the chylous lymphatic fluid that usually you find in newborns. And Kavisha discerned why, because of the presence of chylomicrons, basically.
And I'll reiterate this like 100 times throughout this
Yeah.
presentation.
I wanted to make sure that all of us are like, stating this.
And in the neonate that had been described earlier, the thoracocentesis did note straw-colored fluid with the chest tube, but that was also done immediately after the neonate was born. But when you look at a cellular analysis, or rather when a cellular analysis is done, you typically see large numbers of lymphocytes, greater than 80%. Lymphocytes is pathognomonic for chylous origin pleural effusions. And again, as a reminder, the neonate that had been described earlier had a lymphocyte predominance of 97%. Another rare cause of primary fetal pleural effusion is characterized by subpleural congenital pulmonary lymphanectasia, or CPL. And there are 3 different categories of CPL. The first is generalized pulmonary lymphanectasis. I cannot say this word, which is characterized by the proliferation of the lymphatic spaces and occurs in the lung as part of a systemic abnormal malady involving multiple lymphangiomas found in the bones, viscera, and soft tissues. There's also primary, which is a fetal development defect due to the failure of the pulmonary lymphatics to communicate with the systemic lymphatics. And then finally, there is secondary CPL, which is associated with cardiovascular malformations, including anomalous pulmonary venous return, AV valve defects, ostium secundum, pulmonary stenosis, mitral atresia, hypoplastic left heart, and many others. The presentations for CPL is typically with bilateral pleural effusions and generalized lymphedema. There may be a variable presence or absence of ascites. Now, the diagnosis is usually made on the basis of pulmonary biopsy postnatally. And again, males are more affected than females. The table below is from a study published by Wilson in prenatal diagnosis examining congenital pulmonary lymphanectasia. This paper reviewed other peer-reviewed articles and found that with a diagnosis of CPL, there's actually an autosomal recessive inheritance pattern. The paper also found that CPL cases were associated, unfortunately, with a mortality of 62%. There are also a wide range of potential secondary etiologies for pleural effusions. Today, I will be discussing on the most common. One of the first, so there are various structural malformations that can contribute to isolated pleural effusions. And it's thought to be associated with 10 to 15% of all cases of pleural effusions due to secondary etiology. These etiologies can include congenital pulmonary airway malformation, or CPAM, bronchopulmonary sequestration, or BPS, and right-sided congenital diaphragmatic heart. A paper by Dinksa found that bronchopulmonary sequestration can be associated with lateral pleural effusions in about 6 to 10% of cases, and they typically appear as a solid, well-defined triangular echogenic lung mass, as demonstrated in this image here. Pulmonary sequestration is either classified as extralobar or intralobar, and it depends on whether the sequestration is within a separate pleural investment, or if it's within the pleura, or if it's separate from the pleura. An extralobar mass is essentially characterized pathologically by diffuse dilation of the bronchioles, alveoli, and subpleural lymphatic vessels. It's believed in terms of how this causes a pleural effusion is the torsion of the sequestration with occlusion of the venous and lymphatic vessels that can then result in the formation of these pulmonary effusions. There is also genetic etiologies that can contribute to the formation of pleural effusions. So in 2005, a study by Waller, who performed a systematic review examining 249 studies, fetuses rather, affected by pleural effusions, found that the prevalence of chromosomal abnormalities among fetuses with isolated pleural effusion was 12%. And the overall prevalence of chromosomal abnormalities in all fetuses with prenatally detected pleural effusion was 35.3%. So this is non-isolated pleural effusions. The figure that is on the slide is from the Waller study, and it demonstrates the distribution of chromosomal abnormalities in patients with isolated and non-isolated pleural effusion. And what I really like is that it divides the isolated and non-isolated to look at the most common chromosomal abnormalities. What we can see from here is that the most common chromosomal abnormality contributing to non-isolated pleural effusions was trisomy 21. In 2018, another retrospective study by Wellesley looked at fetuses, again, with and without isolated pleural effusion. Patients were then stratified by presentation prior to 24 weeks and after 24 weeks. In patients who were found to have a pleural effusion before 24 weeks, 11% had a chromosomal abnormality, usually trisomy 21 or 18. In patients who presented with pleural effusions after 24 weeks, 17% had a chromosomal abnormality and 44% had a syndrome, of which half were Noonan's. Other genetic etiologies thought to contribute to pleural effusions include Turner syndrome, Klinefelter, Sly, and Holt form.
Yeah, I'm very proud that Kavisha spelled Klinefelter correctly. Most people spell it, they put the E before the N, and then.
I did that initially and then have to. Another secondary etiology that I would like to discuss is infectious, for Sarah specifically. The infections most commonly associated with the development of fetal pleural effusions include parvo B19 in a study by Perla. 2 out of 6 cases of isolated pleural effusions were found to have recent parvo infections diagnosed by the presence of IgM antibodies in the serum in the absence of structural or karyotype abnormalities. 2 is toxoplasmosis. And again, this is from that study by Wellesley that was discussed in the previous slide, in which 1 out of 12 cases presenting after 24 weeks with bilateral pleural effusions was noted to be affected by toxo, resulting in a stillbirth. CMV is also noted to be associated with pleural effusions. And this was also from a study by Barron, where they considered the cause of non-immune hydrops, CMV to be the cause of non-immune hydrops in 1 to 2% of cases, but also noted that it could be present with isolated pleural effusions. And also syphilis. There was a study in 2015 that found congenital syphilis to be diagnosed in both the fetus and asymptomatic mother following detection of prenatal ultrasonography of transient fetal pleural effusion.
Can I take a minute?
Absolutely.
Just the slide is here. So basically, what we do in medicine is always expensive, correct? So I get these questions, well, the baby has hydrops and an exome. Like, okay, did you do your basic? So think always there could be a non-genetic etiology and then the genetic etiology. So a simple test like parvo, toxo, CMV, and syphilis really should be the basic workup for patients with pleural effusion or also hydrops. Always remember these are really important.
And that actually leads me to my next part of the presentation is now that we've discussed the possibility of pleural effusion, we can discuss diagnosis. So diagnosis of fetal pleural effusions can be made by the identification of isolated fetal pleural effusions surrounding one or both of the fetal lungs under variable forms. You can have mild unilateral effusion to massive. Typically, the diagnosis is made in the third trimester, although it can be also made in the second trimester. On ultrasound, you'll have the following findings. Hypoechoic fluid collections in the fetal chest and diaphragmatic contour. If unilateral and large, and by large, I mean occupying greater than 50% of the thoracic cavity, you can see considerable mass effect on the diaphragm, fattening or inverting and displacing of the heart and mediastinal structures into the contralateral hemothorax. Secondary etiologies for fetal pleural effusions tend to be more symmetric in size with little mediastinal shift. And the presence of septations or solid components within the intrathoracic fluid collection suggests an alternative diagnosis. In severe cases, the lung is much reduced in size and has what was noted to be a butterfly appearance, floating in free fluid and moving with the heart. Unfortunately, I wasn't able to find any videos, that demonstrated this, so I wasn't able to actually clip that.
But you see it when you see the pleural effusion, right? In scans, it's like squished, you know? Yeah.
So here I have a few images that I will just briefly go through. This image here is a transverse section of the fetal thorax. Here we can identify a severe large left pleural effusion. The heart, as a result of this effusion, has shifted towards the right hemothorax. As a result, the left lung, which is right here, is compressed by the effusion. This image also demonstrates a unilateral right hydrothorax in the transverse view or pleural effusion. Again, we note the significant mediastinal shift and compression of the contralateral lung. In spite of the unilateral presentation, the fetus also presents with subcutaneous edema, which in most cases will evolve rapidly to generalized hydrops. This image, once again, is in the transverse view and demonstrates bilateral severe pleural effusion. This is in a 33-week fetus. And again, we're seeing compression of the lungs, but unlike the previous pictures, we're not really seeing that mediastinal shift because it's more balanced in terms of the effusion.
I want the fellows to develop a quick eye for the diagnosis of skin edema. Now, typically we define it clinically if you need an exact number more than 5 millimeters. So really the sonographers need to measure it. But like with the pilot images you showed, it was really clear. So I want you guys to become like very confident and easy to diagnose skin edema.
And this is just a coronal section of the trunk, essentially demonstrating the bilateral effusions. So in terms of additional images for diagnosis, MRI doesn't provide additional information for ruling out primary fetal pleural effusions, but it may help out with ruling out associated abnormalities such as CPAM, BPS, or congenital diaphragmatic hernia, where primary pathology dictates management. Now, unlike other fetal therapies we have discussed in the past, the diagnosis for fetal pleural effusion is very straightforward. So there isn't that much of a differential. It can be challenging, however, in rare cases of massive pleural pericardial effusions, which in some cases may be large enough to occupy half of the thoracic area. In such cases, free fluid surrounding the heart, with the lungs being compromised posteriorly and in close contact with the thoracic wall. Given the extent of secondary etiologies for pleural effusions, once a diagnosis is made, extensive evaluation is necessary. So with ultrasound, you want to look at lung abnormalities, looking for CPAM, BPS, and congenital diaphragmatic hernia. Other things to evaluate for are mediastinal tumors, congenital goiter, which are causes of pleural effusions, but very, very rare. You should also have sonographic evidence of any congenital infections. So looking at the bowels to see, is there echogenic bowel? Are we seeing any intra-abdominal or intracranial calcifications? And a fecal echo is also recommended, as up to 20% of cases of hydrops are secondary to cardiovascular abnormalities. Fetal anemia so in terms of blood work, fetal anemia should also be excluded as part of the evaluation. Normally when you think of fetal anemia, fetal ascites is considered to be more pathogenic, but they still recommend investigating blood type, antibody screening to exclude cell immunization, hemoglobin electrophoresis, and then KB to exclude fetal maternal hemorrhage. Blood work that you also want to send are maternal serologies for parvo, CMV, syphilis, and toxo as discussed previously. And in terms of genetics, you can do invasive testing, CVS or amnio, and also pleural fluid aspiration.
Just things, is it just that they're causing fetal anemia and high drops and you're seeing pleural effusion as a result of the high drops? So it's not like a isolated pleural
Yeah.
effusion situation.
Yeah, it's usually more for high drops, but they're still recommending that to make sure that you're not missing.
The other thing I would just add to the,
Oh, no, you go first.
I was gonna say, the other thing I would just add to your blood work is that, remember, hemoglobin electrophoresis isn't gonna pick up alpha thal. So if you have a patient in whom that is suspected, right, they have a low MCV, they're not iron deficient. This is also going on, consider doing alpha thal testing.
That's definitely a good point.
So this is, can you go back to that slide? So if you forget everything, just you have to remember this. I get tons of phone calls from, I'm a from faculty. Okay, what is the workup? So please, each one should take a picture of this and save it. I don't.
slide later.
I should have a better slide later, but based on. But basically, you know, you're gonna be looking ultrasound. Is there any other malformation that you see? Right, you need the echo, you need your MCA, correct? For the blood work, antibody screen, hemoglobin electrophoresis, MCV, of course, KB test. You may be at an institution, they may do liquid chromatography instead of a KB, okay? And then we talked about the infectious workup. You know, everybody thinks about the amnio, but many times these are the parts that are forgotten among different MFMs. So now, why I haven't seen cases here of fetal maternal hemorrhage. Northern Virginia, I used to see a lot. We used to do like multiple more KBs. So can someone explain to me what is, like, why do we do KBs? Like, what is fetal maternal hemorrhage? Really? And you're not gonna believe it until you deal with cases like that. Probably. And there's evidence for it, publications. So basically, typically, really, you may, we may be doing a 20-week ultrasound, or a patient presents at 32 weeks, she's having decreased fetal movements, okay? And then you may see, pleural effusion, or you may see high drops on these babies. And this is, again, a simple, sure, you can do an MCA and check for fetal anemia. Also, this would be a case where, sometimes you have leaking of fetus cells into the maternal circulation. And then you have a positive KB. And really, the KB can quantify for you, okay, there's 50 cc's of fetal blood. There are tables about that. A baby is so that this is this weight, this is how much we expect blood, and this is how much is the value. So what is the how much percentage bleed is there? And this is typically something that is done by the lab, who usually do this test all the time. So so basically, unfortunately, I've had also cases that I have reviewed stillbirth. Well, she had decreased fetal movements, and everything was reassuring. But then, after the death of the baby, immediately when she was KB was done, and the numbers would be very, very abnormal. So yeah, it's like an asymptomatic thing that can happen, and this is the tricky part about this. So thank you for letting me talk, Dr. Khanuja.
Thank you so much, Dr. O'Flaherty. As promised, here's another picture of fluid analysis. So amniotic fluid that's collected will undergo karyotype CMA, chromosomal microarray, and exome sequencing to look at genetic etiologies. But thoracocentesis collection reviews can also be sent to differentiate the different types of pleural effusions according to different categories. So part of this analysis involves looking at the gross appearance. So red appearance is suggestive of active bleeding, as demonstrated, which you would see right here. Also red.
And it could be secondary to a traumatic puncture too, not necessarily active bleeding that we want into a blood vessel.
Brown appearance is more suggestive of old blood. White appearance is suggestive of a chylothorax, and that's what I had showed previously. If feeding has been initiated.
This is all postnatal.
If the infant has had no feedings, the fluid is typically straw colored. This is what we mean by straw colored.
The one below it. The one below it, Kavisha.
That's more transudative,
Oh, that, okay.
which is more of a pale yellow clear appearance. And that is suggestive of heart failure, hypoalbuminism, and extravasation of intravenous fluid. And then if you have a cloudy appearance or pus, it's suggestive of infection due to bacterial or fungal pneumonia or empyema. I just realized that it looked more pussy on my slide.
So I think the appearance of the pus and your chylomicron are gonna be pretty similar, and they're both gonna be full of white blood cells. How do you differentiate between those two?
Lymphocytes usually.
Which brings us back to our next point. The other aspect of the fluid collection analysis involves looking at the cell count and biochemical processes. So you're looking at protein, lactate, LDH, glucose, cholesterol, and triglycerides. Once that information is obtained, then you can classify the disease process as transidative versus exudative. So for transidate, you'll see imbalances in hydrostatic and oncotic. As a result, the fluid has a low protein concentration and LDH levels with few or no cellular elements. When you see this, etiologies that you want to think of are venous hypertension, congenital diaphragmatic hernia, congenital heart disease, pulmonary malformations, and congenital nephrotic syndrome.
Isn't this like lights criteria?
Yes, that is entirely.
Step one flashback.
Yes. I figured if I said slights criteria, it wasn't going to be helpful, but that's why I'm going through more details. The exudative processes, so the fluid compared to transudative typically are higher protein and LDH concentrations and more cellular elements. The most common cause of neonatal exudative pleural effusion is chylothorax. So the lymphocyte predominant is the most important thing to know. Again, it is pathognomonic, again, greater than 80. And then the other thing I wanted to also bring up here is that triglyceride levels can also be seen in that are elevated in a chylothorax. So you'll see levels greater than 110. Okay, now that we've discussed diagnosis and evaluation, the final part is to discuss management. So the main thing to know is that as overall, the clinical course of fetal pleural effusions is unpredictable, which can make both management and counseling quite difficult. The natural history of fetal pleural effusion is different from chylothorax in the newborn, and it carries a much poorer stenosis. The mortality rate for a chylothorax in the newborn is about 15%. But the mortality rate for prenatal diagnosed fetal pleural effusion is about 53%. Now, this of course depends on if it's an isolated pleural effusion, which is actually associated with nearly 100% survival, or if it's associated with hydrops, where mortality approaches nearly 95%. Spontaneous resolution or regression has been reported to occur in 9 to 22% of primary fetal hydrothorax pleural effusions, even in cases of large effusions, and again is associated with nearly 100% survival. A study performed by Longecker examines adverse prognostic factors, which are noted on the table on the left side, include the following. Adverse prognostic factors include diagnosis less than 33 weeks, bilateral pleural effusions, presence of hydrops, and absence of spontaneous resolution and premature. This is actually very timely based on a conversation we had this morning in terms of predicting pulmonary hypoplasia. It's something that is quite difficult to do, and there's been many studies looking at how can we look at. What we know is that in looking at primary pleural effusions in fetuses who are inflicted by this, we found that the overall mortality rate in the specific study was 35%, with 75% of deaths actually occurring postnatally. And this was all related to pulmonary hypoplasia. So as a result, several attempts have been made to develop ultrasound predictors of pulmonary hypoplasia, but this has been with limited success. For instance, there was a study by Trabwasser who attempted to use 2D ultrasound parameters to evaluate the risk of pulmonary hypoplasia by evaluating the thoracic circumference to abdominal circumference, lung area. And this table below demonstrates the sensitivity and specificity of these parameters. Overall, these parameters have inadequate negative and positive predictive values. And the other thing to know is that thoracic circumference is of limited use in fetuses with pleural effusions, as the chest wall is generally normal. But what the study found was that only at the extremes were any of the ultrasound measures or techniques predictive of pulmonary hypoplasia. Additionally, pulmonary hypoplasia may develop over time, limiting the accuracy of mid-trimester evaluations. So unfortunately, at this time, imaging is a limited modality for prediction of pulmonary hypoplasia. Now, how do we manage fetal pleural effusions? This figure above is a flowchart to demonstrate an approach for management. Most primary and small non-hydropic effusions may be managed expectantly and may spontaneously regress. In the presence of a rapidly enlarging pleural effusion with associated mediastinal shift, hydrops, or significant polyhydramnios, drainage of pleural effusions is indicated. Interventions for thoracic decompression possibly reduces the risk of pulmonary hypoplasia by allowing for the lungs to re-expand. Intrathoracic pressure may also decrease with improvement of venous return, and potential hydrops could also be reversed. Relief of the esophageal compression may result in normalization of amniotic volume, decreasing the risk of PPROM and preterm delivery. And response to the pleural drainage may also provide prognostic and diagnostic information. Now, fetuses that do not demonstrate lung expansion following decompression may be at increased risk of pulmonary hypoplasia. If the hydrops does not resolve after drainage, this may also suggest an alternative underlying cause for hydrops other than pleural effusions. So if you are going to intervene, the goals of antenatal fetal therapy are preventing the lung compression, allowing normal development, prevention or reversal of hydropic changes and hydramnios, avoiding fetal death and preterm delivery, and then improved postnatal respiratory function.
So this might be a really stupid question, but for the lung hypoplasia, that's when, not that you're seeing a small lung on ultrasound, but that once you remove the whatever's possibly compressing it, it stays small, that's hypoplasia. Whereas if it's just compressed because there's pulmonary edema, that's not necessarily lung hypoplasia.
So there's.
You shouldn't think about it as size, it's really function, I think.
Okay.
Lung hypoplasia is meant to be the lung,
So-
going back to.
So seeing a small
I
lung
think
on
it-
ultrasound does not necessarily mean that there's
It doesn't work.
hypoplasia.
Right.
No, it's more like this.
What is the
This
appropriate term for when you see a smaller compressed lung on ultrasound?
I think it's different, right? Because if it's compressed, then it's probably undergoing some kind of hypoplasia, I would assume, because you're not allowed for.
We just said that we can't really predict that from ultrasound. And it sounds like, hypoplasia, it sounds like it's more of a diagnosis
You can't predict the
postnatally.
extent of what
Okay.
will happen postpartum, like in terms of how bad of a prognosis the fetus
I
will.
can imagine there's some degree of hypoplasia. Would you call it like structural lung hypoplasia? Like, cause we just don't know function.
So like, I guess like
Yeah.
when I see the image you showed before where there were tiny little lungs surrounded by
Yeah.
pleural effusion,
Yeah.
what would be the appropriate way to document that in our ultrasound reports?
So to answer you, we have to go back to her long talk on embryology. Remember, she discussed the canalicular phase between 16 and 26 weeks, correct? So basically, it really depends when am I gonna see this hydrops? If I'm seeing pleural effusion for the third time at 32 weeks, this is gonna do much better than the pleural effusion at 18 weeks because we already have had a good amount of this alveolar, all the cells that she named probably would have developed at a good percentage compared, to the pleural effusion that caused so much the compassion. In one of the slides, it was the compassion that actually led to the hypoplasia itself. So I think I absolutely agree. Pulmonary hypoplasia, we discuss it with all patients, right? Whenever, let's say, there's ruptured membranes at 16 weeks, 18 weeks, right? But of course, it's going to be an autopsy diagnosis or a pathological diagnosis. But what we tell the patient is a risk for pulmonary hypoplasia or a risk of respiratory difficulty. So basically, yes.
When I'm describing the findings where I see the small lung.
Small lung volume.
Small in volume, okay.
That's what I would call.
That's the accurate
I
thing.
wouldn't call it lung ablation.
Thanks, Dr. Ruby.
So prenatal therapy for pleural effusion can include thoracocentesis, pleural amniotic shunting, and recently pleurodesis. So I will be discussing these therapies. So thoracocentesis has both a diagnostic and in some cases therapeutic role in managing fetal pleural effusion. To do this procedure, what we essentially do is it's very similar to an amniocentesis. You take a 22 gauge needle that's guided under ultrasound into the pleural cavity. In order to maximize drainage and avoid structures, the needle should be directed towards the lower lateral aspect of the thorax between the mid-clavicular and mid-axillary lines. The reported pregnancy loss following thoracocentesis is actually similar to an amniocentesis. And then you can send the aspirated fluid for the addition of the studies that we had discussed previously. There's also recommendations for repeating fetal echo after initial thoracocentesis based on the severity of the initial compression. Following thoracocentesis, close observation is required for recurrence of the effusion and the timing over which the effusion reaccumulates. So this image right here just shows the needle being inserted through the maternal anterior abdominal wall and eventually ending in the thorax of the fetus with a large pleural effusion. So thoracocentesis was first performed only in 1982 and first in 36-week fetus with polyhydramnios and bilateral fetal pleural effusion. This time 174 cc's of straw-colored fluid was removed with expansion of the right lung. In 1998, a study by Aubard did a literature review of 29 fetuses with primary pleural effusions undergoing thoracocentesis. And what was noted was that fluid reaccumulated in 75% of those cases with a mortality of greater than 50%. And throughout the literature, it's noted that rapid reaccumulation of the pleural fluid typically occurs within 24 to 48 hours post-decompression.
And that's very important.
Yes, because some studies have actually proposed that thoracocentesis just prior to delivery, in order to facilitate ventilation of the neonate, is something that can be done, which is exactly what was done in our patient that we had discussed earlier. Thoracocentesis was done just prior to delivery in hopes that it would facilitate ventilation once the newborn is born. There is a case series examining this, and what they found was that four of the infants who underwent this procedure, all of them were born in good condition, which was defined as spontaneous breathing. 3 of the 4 did require chest tubes, and then 2 ultimately passed away.
So patients will be asking you this question, why don't you take it out? And sadly, sometimes we, the MFMs also do multiple procedures on the same patient. So, which brings us to the second treatment also.
The next procedure is thoracoamniotic shunting. So there are certain criteria that needs to be done if you are planning on proceeding with that. You can only do it if the pleural effusion is likely due to isolated chylothorax, there's normal fetal karyotype, rapid reaccumulation after initial thoracocentesis, or fetal hydrops. Things that you need to take into consideration pre-procedure. So unlike a thoracocentesis, this procedure is carried under sterile technique with maternal sedation often. You can use local anesthesia, which we don't, again, do for amniocentesis or thoracocentesis, so this is how it differs. And they also recommend broad spectrum antibiotics pre-procedure and then continued oral coverage post-insertion. The use of tocolytics is variable and should be used on a case-to-case basis. So how the procedure is done, again, couldn't find a video, so I'm going to try to verbally describe this. But essentially, you have a trocar that is introduced into a pocket of amniotic fluid sufficiently distant from the fetus to facilitate the external end of the shunt into the cavity. Sometimes people will actually use amnio infusion to optimize fetal position or provide a better window of access into the uterine cavity. Once within the amniotic cavity, the trocar is inserted through the fetal chest wall into the effusion as close as possible to the mid-axillary line at the base of the scapula, while also avoiding the nipple. The sharp trocar tip is advanced well into the effusion. The trocar is then removed and a double pigtail silicone catheter is inserted through the cannula. A pusher rod then advances the distal half of the catheter into the fetal pleural effusion. The cannula is then withdrawn, and finally the pusher deposits the rest of the catheter. This pusher, the rest of the catheter into the amniotic. In comparison to thoracocentesis, perinatal survival is improved with thoracoamniotic shunting. In a review of 203 fetuses with primary pleural effusions, overall survival was between 60 to 66% with improved outcomes following shunting compared to thoracocentesis. And perinatal outcomes from actually a large centered case series for thoracoamniotic shunting for pleural effusions are actually summarized in this table alone. In terms of survival, the range is anywhere between 48 to 68%. For non-hydropic, if you're dividing them, it's between 60 to 100%. And for hydropic fetuses, it's between 33 to 66%. Hydropic resolution has been noted in about 46 to 89% of cases. And among those with persistent hydrops or other genetic syndromes have also been caused. So things to also look out for are type 7 mucopolysaccharidosis and aphasia deformations.
Earlier you said that the shunting was done for isolated.
No, so shunting, so if you go back here, fetal hydrops or symptomatic progressive polyhydramnios is also for the criteria. So you must have one, it's
Okay, gotcha.
pylothorax.
It's not all that it needs all of those, it's that it can be any of those.
Correct.
And Sarah, this is like academic institutions like us here, you know, unfortunately, there are some AMAFAMs across the world who would just see a pleural effusion, no diagnosis, nothing. Okay, let me shunt you, you know? So, and yeah, I've seen this at meetings and it does happen.
The main thing to also discuss, which is in this next slide, is like, so you do the procedure, what are the complications associated with the procedure? And this includes preterm birth with delivery occurring less than 37 weeks in 80% of patients who undergo this procedure. The problem is reported anywhere between 6 to 15%. For pneumonitis is 8.5%, and also catheter migration may be seen in up to 20% cases. In a study by Yinyan, of the 88 patients in the study, 27% needed a second procedure, and or about 3 to 4% needed a third procedure. In terms of long-term outcomes, there's not a lot of data. There was a study by Whitlocks who evaluated neurodevelopmental and respiratory outcomes among 48 hydropic fetuses that underwent the shunting for pleural effusions. And what was found was that 41 of the 48 were live-born, and only 31 ended up surviving the neonatal period. 15% of surviving infants were discharged on home oxygen, and 35% required readmission the first 2 years because of respiratory complications. 15% of children also had significant neurodevelopmental impairment. And the final procedure I will be discussing is pleurodesis, which is proposed as an alternative to shunting or adjunct in the case of shunt failure. Typically, we use sclerotherapy for the treatment of venous and lymphatic disorders in adults and macrocytic lymphangiomas in children. The way that it works for fetal pleural effusions is actually similar to thoracocentesis, and it requires the same instrument and same approach, but instead you instill the sclerosing agent after the effusion is drained. Often you use OK432 as the agent, and what this is an inactivated strain of group A streptococcus, which promotes cytokine activity and generates a local inflammatory response. This inflammatory response then increases vascular permeability and thus increasing lymph drainage. So how are outcomes? In a study by O'Brien in 2015 that examined the use in 31 fetuses, 14 actually underwent treatment. And of those 14, survival rate was 85%. And this is only in 13 because one of them decided to go through a termination of pregnancy. And 100% of fetuses that were treated with this procedure who did not have hydrops survived. And of those who did have hydrops, 78% survived. And this actually compares pretty well to the cases of thoracoamniotic shunts in the literature. The mean gestational age at birth was 36 weeks and 4 days, and the mean birth weight was about 3,000 grams. So right now, safety and long-term outcome data is lacking for this procedure, so further investigation is warranted. But the thing is, like, this is a less invasive and technically simpler procedure than shunting, and it may make that as a treatment, which would make it a really good therapeutic option. In terms of mode of delivery, it does not impact outcome, neonatal outcomes, so we just go over reserved C-section for standard obstetrical indications. However, delivery is recommended in a tertiary care center where you have adequate neonatal and pediatric support for resuscitation purposes. And at birth, shunt should be immediately clamped to avoid a normal. This is my summary slide with the picture of what to do for evaluation. So summary, fetal pleural effusions can be associated with significant perinatal morbidity and mortality. In terms of evaluating, looking at both maternal and fetal testing that is appropriate, and again, affected pregnancy should be referred to a regional fetal medicine center with affected pregnancy this is repeated twice, and delivery should also occur at centers with neonatal disease. And those are.
If the chylothorax is caused by abnormal lymph drainage in the lungs,
Yeah.
why do they see high drops in those cases, and why did we see like the in our case of it?
So high drops, basically, I don't know if it has to do necessarily with size, because there isn't necessarily an association with size pleural effusions with high drops, but I think it's just this rapid accumulation that can result in also like chest compression, which then can lead to like other like heart failure, which then can lead to high drops. So it's sort of like this sequence of events.
Gotcha.
And so the goal is like, if you are able to do, so if you have development of high drops and can do this procedure to remove some fluid, do we see a reversal in these symptoms because we're removing it? Or treating?
So it's basically that it's causing compression of the heart, which is then leading to the systemic.
Yeah.
Gotcha.
Fascinating presentation, Dr. Khan. We learned so much.
That was really good.
You know, to summarize again, you know, most of the ones you guys will see, you know, as you're attending and stuff, will be isolated. You know, you do the workup, you know, genetics, structural anomalies, infectious, KB, etc. Most of the time will come back negative. And then the big question is going to be intervention or not. And if this is, again, you know, by reading the literature, unfortunately, there's no randomized study on you do a shunt or serial thing or not. Remember, for laser, you know, in twins there are, for TJUH, so it can be done, then eventually somebody will do it. But right now, we really don't have, if it's isolated, no high drops.
What's the best way to treat
You know, a lot of times you can just, you know, watch it. I think if you have high drops, you know, things are getting better, it's getting bigger. You know, tapping is fine, but most of the time you say 75% or more. Certainly our experience has been like that.
And that's
A
actually,
day or two later, it look the same. Even if you drain it completely, like you showed, you know, Jason's and Neil's case, it just comes back right away.
Yeah.
And the shunt, we've placed many, you know, in the past. And, you know, it's actually a fun, interesting procedure. It's very technical, you know, to put it in so that, you know, half stays in, half stays out. I can tell you, I don't know, a chop, you see a lot of shunts thrown around, you know, you place one, you place two, the baby moves, they move away. Pneumothorax, I'd never seen it, you know, somebody being born with a thing that stays in place all the way till delivery. I think actually the procedure with the sclerosing agent, to me at least, you know, if you're sure that that's what it is, that will make a lot more sense to do a procedure like that to save some to expand those lines again. But again, that needs more therapy. But what I'm saying is, just because you see something there, if it's isolated, not getting worse, there's no high drops. You know, I'm not sure that
Let's leave it.
it's
just
necessary.
going after it.
and
all the
Yeah.
time, it's good.
Yeah, and basically multiple things to be discussed, right? So, you know, what is the outcome of isolated pleural effusion? And this is what, we started this paper with Dr. Rebecca Hogan, and now, you know, Kavisha Kavisha is the one who did review this during her residency. We did the same thing for isolated fetal ascites, and that article really helps us all the time. You know, I get questions about it all the time with a nice table. So, and of course, inspired by Rosella to review these things. You know, you're busy, you're seeing a patient in scans, and you have this finding. How are you going to tell this patient, right? Instead of having to read like so many papers. So now we're focusing on our review on isolated pleural effusion, and what we found actually, if really to answer the question is, what is the chance of isolated pleural effusion to go to fetal HiDOPS? And our first abstract that we presented at our firm 2 years ago, it was around 3%. Isolated ascites to go to HiDOPS, it was around 6.6%. And this is really important information to know how to counsel your patients. You know, I shouldn't be scaring them, because HiDOPS is a completely different disease that is going to have a different, management and outcome and genetics. So, and with the isolated pleural effusion, like we did with the isolated ascites, Neil, also we had a big genetic table for that. We plan to do the exact same thing. We're gonna segregate it. What are the congenital heart malformations? What are the congenital lung lesions that Kavisha have mentioned with infectious etiology? For example, with isolated fetal ascites, we found out that, among the congenital infections, if you are to include all cases, syphilis was actually top on the list if you included the case reports and the case series, which is, oh my God, this is like new information when I shared it with other people. So just to close the loop, because, HiDOPS is something like very dear to my heart. So let's say a patient comes and Kiwi, you're going to do the standard workup, you did the ultrasound and you did the toxo CMV, and, everything came back negative. And then, so she's going to ask you, you did the amnio, the microarray comes back normal. Okay, now, of course, there's a chance that the microarray can come back abnormal for these patients, right? So if the microarray comes back normal, and then you're calling her with the result, and so she's asking you, what's the chance for my baby having a genetic disorder? She's a healthcare provider, the patient, for example, or what's your duty also to discuss with her? So what's the number?
An isolated case.
We're having not pleural effusion, because I don't have the entire data for that, but HiDOPS, which also you're going to be seeing. And honestly, MFMs get anxious when they see these cases. So I want you guys, when you graduate from here, to be, HiDOPS is easy for me, okay? So what's the chance if the non-genetic etiology is negative and you do the basic standard workup microarray, right? So, and then she asks you, anything else I can do? What's the chance of my baby having a genetic disorder?
I would have to look up the percentage, I don't know.
Yeah. Anybody? Huh?
10%?
So basically, based on our exome sequencing meta-analysis review that we published in Clinical Genetics, and I'm glad I brought this up because I thought you guys knew, it's 37%. So that's very, very high. Yeah. So, and we evaluated 450 cases, and we expanded on that. We have 500 now, and it's the same number. So 37% actually have a single gene disorder to account for the HiDOPS. And I'm not talking about variants of unknown significance. I'm talking about pathogenic, likely pathogenic. So we're talking about real stuff here. And if you are to think about, sets of disorders, since we opened the subject, the most common set of disorders that is associated with HiDOPS is what? Huh?
This on storage disorders?
That's number 2.
Esophagus.
So esophagus is number 1. Remember that. And I can go to my office and share that set of genes. I've shown you that before, and maybe we can do another time also before you graduate. So it can be esophagy genes, and then the second set of disorders is LSDs, because with esophagus we have many genes. With LSDs we have many genes also, right? Now, if you are to think about single gene, like one gene that can be the most common cause of HiDOPS, it is piezo1, which is actually causes lymphatic dysplasia. And so whatever you presented, Kavisha, is really important today also, which is under-evaluated and under-investigated. So if we are to think about single gene, which genes are the most common for HiDOPS? It's piezo1, PTPN11, and MPS7. which is GUSP, GUSP, which is mucopolysaccharidosis type 7 that Kavisha mentioned, which is also called SLY. Okay, so so basically this is, but doing this review that we started actually is what let us shed light into all of these details for high dose. What's about high dose for you?
No.
Okay.
Dr. Al-Kwatli, can I ask you a question?
Yes,
Can you hear me, Katie? So that number 37% then is the diagnostic yield of an exome sequencing in a negative microarray in a patient with high drops.
negative non-genetic workup, negative CMV, toxo, syphilis, you know?
Okay, so that
And
doesn't
negative
factor in
inflammatory-
microarray.
I'm sorry?
So that does not factor in, does not include like microarray.
Exactly. So the genetic
Okay.
etiology is really much higher if you look at the overall numbers.
Okay, so but that's the diagnostic yield of a
37%
microarray
negative
or
workup and negative microarray.
No, 37% is just.
no?
Fusion didn't have microarray.
Yeah, they had a normal microarray, they had a normal.
So the majority of the patients in our review had a negative non-genetic workup, which to the original authors, now not all of them, a large number of them. The majority had a normal microarray or karyotype. And then, so what's the yield of the exome? So the yield for the exome is 37%. But what is really interesting, the yield was the same, whether it was isolated or associated with other congenital malformations. And this was revolutionary in our genetics world because everybody always thought, okay, the exome is going to be high when you have a malformation.
So just.
You understand me?
Isolated alone.
So what I'm saying is there's only skin edema and ascites. You know what I mean? And we did the stats and, you know, the stats were similar.
So Dr. Al-Kwatli, is this essentially suggesting, like, if you're going to do an evaluation after ruling out these genetic?
You should do an exome.
So should you skip the CMA? Go straight to the whole exome?
No, then you're gonna go to Kavisha's journal club where she said we're gonna do genome. I'm sorry, Neil, why are you laughing?
You're passionate about this.
No, so you can't. The exome is not gonna tell you the many of the CMA changes.
So you should do them simultaneously.
But the genome can, remember, that's why she presented her journal club 2 months ago. Remember the detailed journal club from the Board Institute by Tolkowski? With the genome, you can skip the CMA and the karyotype because the genome is gonna detect the dosage basically of the.
It's very costly.
Yeah, it's coming. I think.
I believe you.
I hope I can start ordering that before I retire. Yeah, so.
For now, CMA and exome for most
Yeah,
patients.
but honestly, also like how expensive is expensive, right? So here I've had patients, I have ordered genome infrequently. But I think it's gonna become more after that article. So an exome is probably 2,500, 3,000, a genome, 5,500.
It was also the accessibility to the labs too, right? A lot of the labs that we have won't necessarily do the.
Oh, absolutely. There's like very few labs who would do prenatal, but we know the labs that do them.
Right.
So yeah. Okay, so yeah.
Thank you.
I don't think, Kavisha, you could have given a better birthday present.
You opened the door for.
You could just run like straight high drops for your.
I was thinking that. I was like, I really missed the boat. I was like close, but.
You were close enough.